Thank you.
Hi.
It's broadcasting to BI and St. Louis.
Oh, okay.
Screen, that will,
They can hear us?
Yeah.
Okay. All right, cool. All right, so good morning, everybody. So I've conferred with some of our recent graduates and tried to put together what we've termed board favorites. Now, obviously, there'll be questions, I'm told, on molecular aspects of lung cancer and things like that. But as far as the slides go, I've tried to just put together a collection of unusual things that we might not see every day that I'm told have been recent popular items. So the first case is a 45-year-old female with a peripheral pulmonary mass. So this is sort of a classic story. A woman, she's got a peripheral mass. This is usually going to be a well-circumscribed coin-type lesion, if you will, radiographically. So we've got basically tumor only here on the slide. Okay, so who wants to take this one? Did we do that last time, or should I just talk?
No.
Okay.
So as you mentioned, the whole slide is a whole tumor, and then you see like malignant tissue, and here I see a lot of papillary growth, papillary patterns,
Right.
And there's vascular pores, and obviously that this the tumor cells has a little bit of outlaying or visuals. It looks, again, it's basically just papillary architecture, and it's probably adenocarcinoma.
Okay, so that's a very important thing in the differential, and that's not what this is actually. So yeah, no, but it's a big pitfall, and there's actually literature about how difficult it is to separate this at the time of frozen section or on a cytology or small biopsy from papillary adenocarcinoma. So as you've noted, we do have a prominent papillary architecture here. The tumor, it's a little hard to tell, but it's very well circumscribed, not really encapsulated though. It's got some areas that are a little bit more solid and some areas where you've got this fibrosis, and sometimes you'll see bigger areas of fibrosis than what you've got here. But the main thing that you want to look at is these papillary structures and see how they have, rather than a true fibrovascular core, let's find a nice area, they've got an outer cell layer and an inner cell layer. So we'll try to find the best example here. So here's a more solid area. So like you said, you've got the hobnail cells around the periphery here, and then you've got this other group of cells on the inside.
Right.
So you really have to be paying attention to that. And they'll often be papillary, they'll have solid, and sometimes they'll have a fair amount of sclerosis with them. They often tend to have a lot of hemorrhage and blood in the background. So this tumor went by a misnomer for many years and has only been recently reclassified in the current WHO classification as a more proper name for it. So you have outer cell layer and inner cell layer. So both the outer cells and the inner cells are going to be positive for TTF1 and EMA. Only the outer cells will be positive for CK7, and the inner cells can be positive for ERPR some of the time. And interestingly, the outer cells tend to stain for napsin, while the inner cells not so much. So it's a little different compared to the TTF1. So what do we think now? Right, so sclerosing hemangioma is the old name for it because these do tend to be pretty hemorrhagic, and so it was thought these were a vascular tumor. But as we've described with the staining pattern, they stain more like type 2 pneumocytes with the TTF1 positivity. So here's a nice area here. So you have your outer cells and then your inner cells, which are just brilliantly called round cells. It's really unclear where they're derived from, although it is thought to be a type 2 pneumocyte-derived tumor given the staining pattern. So the new name for this, which our British friends have actually been using for quite some time, that's actually more correct, is sclerosing pneumocytoma. And sometimes you'll have these foam cells. This one doesn't have lamellar bodies. Sometimes you'll see those surfactant swirls around that are present in a lot of slow-growing tumors of the lung. These are benign. There's rare case reports of lymph node metastases in these, but those handful of cases, it's not felt to affect prognosis. So these were recently moved into the adenoma category in the current WHO book. So when you're thinking about this, if you've got a woman that's kind of a little bit young for lung cancer and a lot of papillary structures, you want to look for this dual cell population in the papillary cores. So that's your tip off there. But I think every single one of these we've gotten has been called papillary adenocarcinoma and frozen. So certainly, you know, don't feel bad. And you really have to have a high index of suspicion on frozen in particular to get this right. And then, you know, pay attention and just keep this filed in the back of your head for signing out permanents. So that's sclerosing pneumocytoma.
Is these those histiocytes is the feature of it, or just
They can be there. They're not necessarily part of the tumor. A lot of them have it because anytime you get a slow-growing tumor of the lung, you can get some obstructive features. So you'll get the histiocytes, and as I mentioned, you can get those giant surfactant swirls as well. So you can see those around with it also. Okay, so case 2. Okay, so this is one you really should know. Okay, so this is 35-year-old female with diffuse cystic lung disease bilaterally. So classic story again for this. Sometimes these patients have a chylothorax. Okay. So who wants to tell me what this person's got going on? Cystic disease in a young woman.
And there are a lot of dilated lung spaces that we see, and also apart from alveolar dilatation, there are other cystically dilated areas as well. And some of these they seem to be lined by a thickened fibrous layer, and as we can see, there is some monomorphic spindle cells which are lining this thickened wall of these cystic spaces. And there is not much of inflammation, but just some mild chronic inflammation that's going on. And yeah, here actually it seems that there is a very thickened wall in that cystic spaces, and they seem to be like smooth muscles.
Right, muscle.
Right.
Okay.
So it can be a possibility of lymphangiomyomatosis or something like that.
Right. So what stains do you want to get on this?
HMB45.
Right. So yeah, this is kind of a classic story and classic histology for lymphangiomyomatosis. So this is in the spectrum of the PCOMA type tumors. There's been debate about whether this is truly a neoplastic or non-neoplastic process, but it does tend to be aggressive. So it is in the WHO book under the PCOMA tumor category currently. So this is one of those things that you can see in association with tuberous sclerosis. You can also see it without tuberous sclerosis as well. And classically, it's in reproductive age females. There are rare reported cases in men, and it's thought that it's perhaps underreported because if you look at men with tuberous sclerosis, they may have asymptomatic cysts in their lung. So it's thought that it may be underreported in men. But your classic history is a reproductive age woman with cystic disease. Chylothorax, I think, is one of those things that's often in the history that's more commonly used in a test question than you see in real life, but nonetheless, that's a typical association. And since it's one of those picomatous tumors, it is going to stain with HMB45. And even though it's difficult to appreciate, there are actually two types of cells here. So you have smooth muscle cells, which are more spindly, and smooth muscle cells, which are more round. Personally, I have trouble, sorting that out. They all look pretty much the same to me, but theoretically, you do have two cell types. Both of them are going to stain for actin, and one of them is going to stain for HMB45 more so than the other, although they both can pick it up. But HMB45 is like your buzzword for your stain for this. And then you would just want to keep in mind other things that typically go with tuberous sclerosis, so angiomyolipoma, typically in the kidney. Rarely you can have that as a lung tumor. The clear cell or sugar tumor is also in the picoma family, so that's going to stain with HMB45. Sometimes you can actually have cystic disease where you have the clear cells analogous to the sugar tumor in the distribution of Lamb. Very rare, but you can have that going on as well. And then I don't think this case had it, but you can also have multinodular type 2 pneumocyte hyperplasia in a case of Lamb, and it very much looks like atypical adenomatous hyperplasia, but it's not. So if you see Lamb plus that, then that assuredly goes with tuberous sclerosis, whereas Lamb without tuberous sclerosis typically doesn't have that. And then more recently, these patients have been shown to have elevated serum levels of VEGF-D. So you want to file that away. And as far as treatment, these cells will stain positive for ER, but unfortunately hormonal manipulation hasn't really panned out as an effective treatment for these. Some patients respond to sirolimus and other mTOR inhibitors, but unfortunately a lot of these people will end up going for transplant. But that's an entity with just chock full of things begging to be made into questions, so you want to be familiar with that one. Okay, so along our cystic lung disease route, here we have a 40-year-old female with diffuse ground glass infiltrates bilaterally, as well as cysts. So when you have somebody they're telling you has cysts, there's a few things that you want to think about. So Lamb, that we just discussed, is one of them. We'll talk about another one coming up. There's another rare entity called Birt-Hogg-Dubé syndrome, where you have skin lesions, renal cell carcinomas, and lower lobe cysts. And often the cysts will precede the renal disease or the skin disease. So if you've got somebody that's got cysts in their lower lobes as opposed to upper lobes that walks in the door with emphysema, you want to think about that. And then there's this entity. So classic for this is ground glass plus cysts. Now, curiously, the cysts we never really see histologically. I don't know if that's just because of the way they're biopsied or they collapse or something. But we've got some spared areas here, but really this was in every single slide, kind of diffuse all over the place. And we don't get too many biopsies of this, which is why I want to show you this, because usually the story all fits together nice and neat, so they don't necessarily do a biopsy. So the reason this person went to biopsy was they had a mass, which ended up not being anything, but it gave us a nice background lung to look at.
Mm-hmm.
Okay, so what do we think of this?
That interstitium appears to be widened and thickened and filled with mostly plasma cells, which look mature, and also some lymphocytes as well. And the plasma cells, many of them have Russell bodies inside. So they look like reactive plasma cells and admixed, mature-looking lymphocytes. So that's the histology that's most prominent.
Right. So you've got diffuse interstitial infiltrates, and as you mentioned, they're quite marked. So they're actually expanding the alveolar septa. So that's what you want to see. So with this entity, it's usually so much inflammation and infiltrates that you start thinking, wow, could this be a lymphoma? And indeed, you know, we did cover for that, and there's no light chain restriction or anything like that here. But you've got infiltrates expanding the alveolar septa, involving the lung in a more or less diffuse fashion. So polyclonal, no features suggestive of lymphoma. Architecture's preserved, even though you've got marked lymphocytes. So what do we think this is called?
Is it lymphoid pneumonia, lymphoid interstitial pneumonia, or something like that?
Right, lymphocytic interstitial pneumonia, or LIP. Okay, so classically, what underlying disease is this patient going to have? Two things you want to remember for this. This is pretty rare, and you usually only see it in a relatively narrow range of patients. Okay, so when you get somebody with interstitial lung disease, what do they need to be worked up for in general? What big category of diseases go with interstitial lung disease?
Connective tissue disease.
Right, connective tissue diseases. Now, one of the connective tissue diseases in particular goes with lymphocytic interstitial pneumonia. Which one is that?
SLE, no?
Other one that starts with S.
Sjogren's syndrome.
Sjogren's, yes. Yeah, so classically this is going to be seen in Sjogren's. And many of the earlier papers will talk about how LIP is the most common pattern that you see in Sjogren's. Actually, NSIP is more common now that we have NSIP better defined. And how you tell those two apart is LIP again has the classic radiology of ground glass and cysts, whereas NSIP just has ground glass. But under the microscope, LIP actually expands the alveolar septa, so it's just this really in-your-face lymphoplasmacytic infiltrate, whereas NSIP is much more subtle, very mild to moderate without the expansion. I suppose theoretically you could have a case where does one stop and the other start. So far I've not encountered that myself. They're treated pretty similarly, so that the main thing is they need to be worked up for underlying disorders. And this one typically goes with Sjogren's. You can also see this with immunodeficiencies, so pediatric HIV patients are another big category of people that get this. Now, these people are predisposed to getting lymphoma. It's thought now that just arises de novo rather than LIP turning into lymphoma, although there's still some debate about that. But it's thought that those cases were actually lymphoma from the outset rather than LIP turning into lymphoma. But certainly that's something that you still need to watch out for in these patients. Okay, so that's your second cystic disease. So know your associations there. Okay, and then finally, we've got this guy. Okay, so this is the 40-year-old male with diffuse cystic disease. So we've got a male cystic disease. And again, the cysts aren't often as obvious on histology as they are with the Lamb case. But this is sort of the second thing, or one of the main things that should pop in your head when you've got a cystic disease. So
is there any clinical history? Some smoking or something?
He may be a smoker. Okay, so, he's a smoker. All right, he's a smoker, and he's got cysts, and he may have a pneumothorax. That's another thing that classically goes with the history that you're often provided, although in reality you don't see that as much as it's asked about. But the classic story is it's a heavy smoker with a pneumothorax and cystic lung disease. Okay, so we're going to look at this area here. And low power, when we look around, you can see So he's got, areas of, not the best looking lung, but at least no interstitial infiltrates per se. He's got these smoker's type macrophages around the periphery with the finely granular brown pigment. But over here, his alveolar septa don't look too bad. And then we start getting into these areas, which sometimes it's a little hard to tell about location, but they're classically around airways, and they tend to have a stellate morphology. So here's one where you can sort of appreciate it's got a stellate or a Medusa head type configuration, and here you can see the edge of the airway over here. So you've got airway-centered patchy disease, and if you look at these areas on high power, okay, what have we got here? Here's the nice area. Okay, so we got these guys.
Eosinophils.
Eosinophils. Okay, so we got eosinophils, and then we got these guys here. So, and some of them have nuclear grooves, polygonal cells. So what might those be?
LCH, right?
Yeah, so special histiocytes. Okay, so this is Langerhans cell histiocytosis of the lung. So again, classic, usually more males than females, but something about a younger male smoker, cystic lung disease, maybe with a pneumothorax. And this is kind of an active area here. As the disease progresses, it'll become more fibrotic. So sometimes you'll just end up with a scar at the end and so-called burnt out LCH, but these are nice active areas in these slides here. And usually when you've got the story of the male smoker with LCH, that is different from the pediatric disease where you have multisystemic disease. Usually these people just have disease confined to the lung. Okay.
So don't you think that so this disease is now a misnomer, right? You have LCH otherwise, which is a systemic disease in children where you can have multi-system involvement, and you have LCH in the lung, which is not neoplastic, which is just related to smoking, and it goes away. So this is not a proper name.
It does seem to be two different things, and interestingly, people have looked at that because the pediatric disease, a lot of them have BRAF mutations, and then so we thought, okay, this isn't going to be BRAF positive, but some of these cases are, so it's still not quite sorted why this disease is one thing and the other one is another. So project for you.
It seems like it's just the morphology, which is the same, but
it does.
I mean, it's not well defined.
Yeah, but this, can progress. You can get end-stage lung with this. You do have patients that end up having to go to transplant because of this, although that's not very common. Most of the time, if you can get them to quit smoking, maybe give them some steroids, they'll kind of stabilize and get better. And then there are patients that we just kind of run across this incidentally. So yes, unanswered questions about this disorder. For purposes of test taking, what are these going to stain for? Want to know your stains. CD1A and Langerhans and S100, right? So those are the big three that you want to know for that, for Langerhans cell. And then even though probably nobody's done EM on one of these since like 1970, what might they show ultrastructurally? Right, Burbeck granules. So that's thank you. Yeah.
That's Jack from St. Luke's.
Thank you, Jack. Okay, so Burbeck granules, those are the things that look like, we always called it a tennis racket, although the med students told me that nobody's used a tennis racket that looks like that since like the Jimmy Connors era. So we'll say it's like a badminton racket, I guess, but nonetheless, you've got the big round paddle-shaped end on a stick, if you will, and that's a Burbeck granule. Okay, so those are your cystic lung diseases, just begging to be asked about. Okay, now we're going to switch gears a little bit. So this was a 67-year-old female with a hilar mass and multiple satellite nodules. So this case was quite a mess when we got it. I think it took about a week and a half to get this one sorted out. So a lot going on with this individual. Okay. Okay, so low power, we've got a big mess. A lot of it inflammatory. We'll have a closer look at that. This is really her main problem just from a sheer volume standpoint. And then she also has this going on down here. Okay, so let's get the easy bit out of the way. Okay, so she's got this going on down here.
Like squamous cell islands.
Right, right. So just a squamous cell carcinoma. Okay, so she's got that. So you've got individual cell keratinization, nice flat sheets of cells, invading, kind of solid growth type pattern. Okay, so she's got that. Now, that was practically an incidental finding. Okay, so if we go back and look at all of this mess she's got going on over here. It's a nice area. So she's got too many things going on. Okay, so she's got these giant cells and some granulomas. We'll get back to that. Okay, this is a decent area here, I think. Okay, so she's got this kind of infiltrate in the background, or really all over her lung, not really the background. So how would we describe this infiltrate? So we've got
Mixed infiltrate.
mixed infiltrate, great. Okay, so we've got these guys and these guys.
Yeah, lymphocytes, histiocytes.
Right, so we've got some big ugly looking cells with nucleoli and some smaller lymphocytes in the background. Here's something with a mitotic figure. And this one, I don't think I brought the slide that had a lot of necrosis. Some of these had a lot of necrosis in the background. So you've got, so here's an area of necrosis here. Okay, so you've got big lymphocytes, little lymphocytes. So necrosis, mass. Now this was kind of a red herring here, so we'll get back to that. So normally this disease should not have giant cells. So that was kind of a confusing aspect of this case. So let's just pretend those aren't there for the time being. And you've got big cells, little cells, and they're lymphoid. So what do we think about that?
Can we think of something like Arden's sister or something? Or some form of a lymphoma?
Okay, some form of a lymphoma.
Balt or...
Okay, so BALT's going to be, or multoma or extranodal marginal zone lymphoma is the most common primary lung lymphoma, but that's going to be all small cells.
Lymphomatoid granulomatosis.
Right, okay, so tell me about lymphomatoid granulomatosis.
Most of the time bilateral.
Bilateral.
Right, so this lady did have some stuff on the other side when we went back and looked at her more carefully, but most of her stuff was on one side, so that was a little unusual about her. And what else? So what should the big cells stain for?
EBV driven?
Right, so we'll look at some stains in a minute. Okay, and then classically, you've got the big cells, which should be what kind of lymphocyte?
B lymphocytes.
B lymphocytes, right. So the large, ugly cells are B lymphocytes, and you can have varying numbers of those from few to pretty much the whole thing being all the big B lymphocytes. So you have 3 grades, 1, 2, and 3. But it's basically classified as a B cell lymphoma. Previously, that wasn't really thought to be true until you got to grade 3, but now they start off treating them for the most part, even if you've got grade 1 as a lymphoma, so they don't progress. And then the background small lymphocytes are usually what? T, right, because when this was first described, it was thought to be a T cell process, but then it was noted that the big cells are actually B cells. So we'll look at some stains for this one. Okay, this is just the P40 in her squamous cell, so you can see how that worked. So there's her squamous cell kind of sitting all in the middle of this. And then this was her CD20. So a lot more big cells than you might imagine here in these areas. So you can see that it is the
area for stains.
yeah. So you can see that the big guys are staining with the CD20, and then this is the Eber on this case, which is wildly positive. Okay, so we've got lymphomatoid granulomatosis. Now, this patient actually had granulomas. So that was kind of confusing because even though this process is called lymphomatoid granulomatosis, it shouldn't have granulomas. So you usually don't see giant cells and true granulomas in this process. It was really named that just because of its necrosis and resemblance to Wegener's when it was originally categorized. But this patient has actual giant cells and granulomas around, so that was confusing. But as it turned out, what brought this patient into the hospital to start with was she had a Burkholderia pneumonia.
Wow.
So that's what's causing her granulomas. And I actually had to check that myself. It can make granulomas. So I'm going with that. She ended up not having TB or fungus or anything like that. So she ended up having lymphomatoid granulomatosis is most of the stuff going on in her lungs. She had the squamous cell, and then she has this presumably resolving Burkholderia pneumonia that's actually causing the granulomas, which are sort of a confusing picture in this case. Okay, so that one took a while to get sorted, as you can imagine. Okay, so this one, okay, a little bit change of gears. This is a 50-year-old male with a lower lobe opacity. So your key here is this is lower lobe. So you want to be thinking about things that might happen in the lower lobe. Okay, so we've got some emphysematous lung, but the main thing you want to look at is this kind of stuff here. So we've got, you know, kind of a solid looking area here. Some fibrosis associated with it, inflammation. And then we've got, what do we see?
So there's a lot of like lipid structure,
Mm-hmm.
like lipid, and there's a lot of inflammation. So there's maybe like aspiration of some type of pneumonia. Maybe.
Okay, yes. So very good. So you get something in the lower lobe, classic location for this. And what we're seeing here are all of these spaces. And the spaces are of variable size. So that's a key feature of this. So you get some big spaces, you get some little spaces, you get some inflammation and fibrosis associated with it. And then the big spaces in particular, you can see giant cells around the edge. So this is, as you mentioned, this is lipid. So this is a nice example of what's called exogenous lipoid pneumonia. So your classic story with this is, I have no idea why somebody would do this, the oily nose drops thing. I've also seen cases where for some reason people will have their marijuana cigarette and then roll it in Vaseline and then roll that in cocaine and smoke it so they get it. This, I don't ask me. I've seen cases like that. But anyway, anything where you're like aspirating lipid or inhaling lipid like that, usually with some sort of recreational or medicine type use, will cause this. I did have a case, somebody was burning like pine logs with a lot of creosote inside their house. So it was kind of a combination of biomass fuel mess with exogenous lipid pneumonia at the same time. But the key thing is you want to think about it, because sometimes you'll just be like, what's going on here? You've got this big mess and somebody's got a mass. So clinically they're thinking it's going to be some kind of cancer. So you want to recognize this for what it is. So this is exogenous lipid. Unfortunately, once it's processed, you can't stain it for oil red or anything like that. But if you had fresh tissue, you could do so and see the lipid. And this differs from so-called endogenous lipid pneumonia, which is usually due to some sort of airway obstruction. So that's where you get tons of those foamy macrophages. Usually the vacuoles are all fairly uniform. So you don't have this stuff out in the interstitium. You don't have a giant cell reaction to it or a fibrotic reaction or something like that. Okay, so classic story, lower lobe mass, somebody using oily nose drops. So a non-neoplastic, something to keep in mind for a mass lesion. Okay, now here we have an 84-year-old female with a left upper lobe nodule. So this one's kind of fun. Focus. Okay. So what do we have here?
Necrosis.
Is it?
Or fibrosis.
Is it?
Is it amyloid?
It is amyloid. Okay, very good. So you've got some pink stuff forming a mass in the lung. So low power, sure, yeah, it looks like necrosis. I won't fault you for that. Could be fibrosis. But then when you look at it more closely, you can see it's got this kind of chunky look to it. And around the periphery, it often has this giant cell reaction because it's the lungs thinking it's foreign, so it's reacting to that. So you tend to see a lot of giant cells with it. And sometimes it can calcify, sometimes it can make bone. But classically, it's going to have at least some degree of giant cell reaction to it. Okay, so amyloid in the lung. So this should be positive for what?
X.
Okay, it can be either AA or AL. And if you stain it, what is it going to stain for? Congo red, right? That's your Congo red. Yes, very good. Okay, classic Congo red is going to be positive, and we have our Congo red. I don't think we've got a polarizer on here, but we can see that it is indeed staining red. So this polarizes for your nice apple green birefringence. Now, just as a side, before we get to part 2 of this case, say you had something that looked like this, and maybe the pink stuff was a little ropier looking, and it was negative for Congo red. But same idea, you've got big blobs of pink stuff with a giant cell reaction, maybe slightly chunkier looking, but basically looks the same, but negative for Congo red. What do you want to think about there?
And it would be large like this or smaller?
It would be large like this, maybe multiple nodules. But it's the same idea. So
Not proteinosis.
no, that's intraalveolar. So you got pink stuff that looks like amyloid, but it's Congo red negative. So what other deposits can look like amyloid? Okay. I'll put you out of your misery so we can move on to part 2 of this case. So, okay, so you just want to keep it filed away, systemic light chain deposition disease.
Oh, light chain.
Yeah,
Okay.
so that can deposit in the lung, look pretty much for all the world like amyloid. But rather than the beta pleated sheet, it has more of a granular appearance by EM. So it's just something to keep in mind when you're like, this has got to be amyloid and it's not staining. Okay, so this person also has some interesting stuff going on around the side. Okay, so people that have amyloid nodules in the lung, normally it's just a nodule. They can occasionally have systemic disease. But what's another thing that people with amyloid may have driving their amyloid production?
Plasma cell proliferation. Plasmacytoma or something.
Right? Okay. So if we look
Like
at
infectious consumption.
I can't hear him.
He says chronic infectious process.
Right. So chronic diseases, classically you might have an underlying myeloma or something like that. Or any sort of, chronic underlying disease can produce amyloid that's associated with a lot of chronic inflammation. Now this person around the periphery, you can see has a pretty brisk inflammatory process. We've got a lot of plasma cells here.
Mhm.
Also some small lymphocytes going on. So here. All right, so do we think this person just has amyloid or do we think they have more than one thing?
Some lymphoma going on, lymphoplasmacytic lymphoma.
Right, so this is the kappa lambda, which actually worked on this patient.
Because it doesn't work.
Yeah, a lot of times it's not very helpful. I didn't bring like all the stains on this, but so this is the kappa lambda. So this is our kappa here, and then the lambda here, which you can see is staining much less, basically dead negative over here. So we have a kappa light chain restriction. And otherwise, this patient's IHC did pan out to be a malt lymphoma. So sometimes you can get a malt lymphoma that has a lot of plasma cells in it that's different from plasmacytoma. And that's just another thing you want to keep in mind when you've got amyloid in the lung, because some malt lymphomas do produce a lot of amyloid stroma. And some people believe that amyloid nodules are all burnt out malt lymphomas. Now, I would believe maybe some of that's true, but since we can get AA amyloid nodules in the lung, that wouldn't really fit with it being a burnt out malt lymphoma. So I think that maybe some of them are and some of them are not. But as I was saying, most of the time, amyloid nodules are just a single thing. You do want to look for a lymphoma underlying it. And then from a clinical standpoint, they do need a workup because not all of them are going to be isolated to the lung. Okay, case 8. This was 30-year-old with bilateral infiltrates. Oh, this is a good one. Okay. Okay, switching gears. Okay, this was an autopsy, actually. And I realized I forgot to bring my stain for this.
HIV positive.
This is an HIV positive individual. Now, why would you think that? You are correct. An old school case of HIV as
That's
well.
Yeah.
And we have both.
Yes.
and pneumocystis.
Right. Okay. So this is
CMV.
stunning case, really. Okay. So we have two things going on here. So all of these viruses that have, classic pictures, microorganisms that have classic pictures, begging for someone to show you a picture of it. So you want to know those. Okay, so this is, as you said, cytomegalovirus. So it's megalo. So the cells are big. And this is the one that will have intranuclear and intracytoplasmic inclusions. So you want to remember that for CMV. Very nice inclusion here. Sometimes it's hard to see both in the same cell, but they do technically have both. And this guy, as you can see, is just loaded. This is just a truly amazing case of CMV. And then, as you also noted, he's got all of this pink stuff in the alveolar spaces. And I apologize, I realized I forgot my GMS stain, but this has this bubbly, frothy appearance. So this person does have pneumocystis also. So GMS would be positive with that. Your organisms are going to be about the same size as a red blood cell, dark rim, central dot, no budding. Okay. So make sure you know your organisms. So that's a fun one. Okay, now here's a guy that we just had. Okay, so this person has a history of some kind of carcinoma, liver tumor here, so it must be liver cancer, but he came in with this rapidly enlarging mass, which they did a core of. So we just had this one last week. And it unearthed a laboratory problem, much to my dismay. Okay, so basically, we don't see any liver tumor. So what we've got is a big inflammatory mess. Not really, it's got some histiocytes around, not making great granulomas than what we've got here. So basically, you've kind of got a inflammatory mess with necrosis. Okay, but regardless, inflammatory mess with necrosis, you want to be thinking about infection. And here in this bit, okay, if I can not spaz with the scope. Okay, so I think that's our highest. Yes, that's the highest. Okay, so we've got kind of hard to see, but these things here. Okay, so what do we think about these? Okay. Well, we want to rule out mycobacteria. So basically, you do your usual sets of stains. So you're worried about mycobacteria, you're worried about fungus, and usually, even though the classic answer for this organism is that it's gram positive and modified acid fast positive, usually the GMS stain picks them up.
Nocardia.
And yeah, it is nocardia. Unfortunately, our gram stain has been doing all sorts of weird things lately, so that did not work that well on this one. So I got a Steiner stain on it, knowing that nothing is going to get by that. Just so you can see how many organisms are here. Even our gram stain did not work that well, which is quite distressing. But this is the Steiner stain. So you can see that these are filamentous bacteria, and a lot of them. So they kind of have more of a dispersed pattern. So your differential here is basically nocardia versus actinos. So you want to know your classic answer for that. So classically, nocardia is going to be positive for gram, positive for modified acid fast, whereas actino is going to be gram only. Now also, nocardia they used to call it Chinese letters, which isn't PC anymore. To me, it looks like it's just sort of like thrown down there. It's much more dispersed and kind of all over the place, whereas actino tends to make those little cohesive balls, often with sulfur granules like you'll typically see in the tonsil. And this is the gram stain on that, which much to my dismay, we discovered we also seem to be having a problem with our gram stain, but it did at least stain somewhat on here. Highly disappointing. All right, so another lab problem to investigate. They were so weak, it was just distressing. Yeah, so there you can see they're just barely staining, which is just not acceptable. So the lab's working on that. So anyway, but that's Nocardiosis. So just so here you can again see they're just barely picking up here, which is sort of bothersome. So we're working on that, but nonetheless, another organism that you always want to think about in your armamentarium of things that produce a big necrotic mass. Okay. Now in contrast, we've got case 10, which is a 50-year-old male with a lung nodule. Now this can produce a necrotic mass. It can produce a big necrotizing granuloma. It can produce a fibrotic mass with a bunch of histiocytes. It can produce no reaction. It can hide in capillaries. So this one is more of an example of what's called the fibrohistiocytic inflammatory type mass. This one does have giant cells around, so it's at least trying to form granulomas a little bit more than these sometimes do. And what pattern occurs in these patients basically depends on their immune status. So this organism can affect both immunosuppressed and immunocompetent individuals. And you can usually see it on H&E if I can keep my hand steady. So here we've got, so we've got these spaces, and you can kind of make out these guys in the spaces. Okay, so what do we think those might be?
Cryptococcus.
Cryptococcus, very good. Okay, so classically, these are going to have this halo around them because they have a big mucoid capsule. And what's our classic question about Cryptococcus because it has a big mucoid capsule? Okay, so for your spinal fluid, you'll usually get an India ink because the ink will run that off and you can see them floating around. So on your histology stain, so like since it's a fungus, it's going to stain with GMS. And classically, they're going to be variable in size. So some of them can be small, some of them can be large. And they typically have narrow-based budding. So you want to remember that those go together. And sometimes when you get a bunch, it's a little harder to tell like what's budding and what's just two on top of each other. But you want to remember variable size, narrow-based budding with these. So here's one. It's cute. Yeah. Is that on the screen?
Yeah.
Okay, so narrow base budding, that may be one there too. Okay. And then one thing that just loves to be asked about crypto is the fact that it stains with mucicarmin, right? Very good. Okay. And I always find the mucicarmin stain much more disappointing in real life than it is in robins. But nonetheless, it is mucicarmin positive. So here you can see that it's picking up here. Very disappointing, I think, but nonetheless, they're there. So you want to know that they are mucicarmin positive. So that's something that's very popular question. Okay, so just while we're on Cryptococcus, you always want to be thinking about Cryptococcus because it can look so many different ways in the lung. As I mentioned, it can be a big granuloma, it can be a fibrohistiocytic mass like this, it can have no reaction, you can have just a mucoid pneumonia with the organisms floating around everywhere. And sometimes you will get a capsule deficient type of Cryptococcus. Now that can be difficult to tell from histoplasma because some of the smaller size crypto will overlap with the size of histo. You'll still tend to see more variability in size, but you can get duped by that because your mucin stains are going to be negative in that situation. So one thing that can help you with that is that Cryptococcus will stain with Fontana masson, whereas histo won't. So that can help you if you've got a capsule deficient crypto. Okay, and then our last case, 50-year-old male with multiple cavitary nodules. Huge mess. Okay, what do we think of this one? He's very sick, I would say. All right, so low power, it looks very blue, right? Okay, and over here where it's not such a big mess, we have irregular areas of blue. And when we look at these areas, we can see that they're blue because they are necrotic and they are loaded with neutrophils. Okay, so neutrophils blue. Okay, so very basophilic type necrosis, and then it tends to be very irregular in shape. So it's the geographic pattern of necrosis that you've read about. And then around the periphery, you've got individual giant cells. So what you don't see here are well-formed granulomas like you might expect to see with, say, sarcoidosis or TB or something like that. The giant cells are just sort of randomly dispersed around the edge of this. One here, and so forth. So you've got a bunch of blue necrosis, you've got random giant cells, and then you've got here, what's this? Vasculitis. Very good. Okay, so we've got big blood vessel here that's being totally chewed up by neutrophils. So this process will typically involve medium-sized vessels downwards. Sometimes you can have a capillaritis component, and the vasculitis doesn't necessarily have to have giant cells with it. So it can be just neutrophilic without the granulomas, or the giant cells rather. Okay, so what do we think this guy's got? Wegener's, right. Okay, so this is pretty classic for Wegener's, or what we're now calling granulomatosis with polyangiitis. So you'll have geographic areas of necrosis, scattered individual giant cells as opposed to well-formed granulomas, and vasculitis. So take-home messages here. You still need to stain this for infection. Fungal infections more commonly than mycobacteria can look like this, and blastomycosis in particular can have neutrophilic areas of necrosis, but typically the granulomas are better formed and round. So if you have a case like this and you start seeing well-formed granulomas, you really want to think about infection instead of Wegener's. If you have one lesion instead of multiple cavitary lesions, you want to think about infection instead of Wegener's. But then otherwise, if you've got this pretty classic histology with the dispersed giant cells and the necrosis, even if you don't see vasculitis, you can still suggest the diagnosis to the clinician. And on serology, what are these patients going to have? ANCA. C ANCA, right. And C ANCA goes with what? Okay, so P ANCA goes with myeloperoxidase. So C ANCA goes with
Proteinase.
Proteinase, serine proteinase 3. All right. And then these people classically will have sinus disease and renal disease also. And you really want to remember your ANCA. So the reason this typically doesn't form nice granulomas like you see with an infection, you can think of it being almost backwards from an infection. So if you've got an infection, the granuloma is trying to wall off the infection, so it makes a nice tight granuloma, whereas Wegener's is more of an autoimmune process. So the ANCA either directly or indirectly is causing necrosis of the collagen, and then all this stuff is reacting to it. So you've got the giant cells just scattered around. So it's kind of the reverse of a granulomatous infection, if you will. You want to know C. ANCA. And then you also want to know some of these occasionally will have P. ANCA, very small percentage. Histology looks the same. If you have limited Wegener's or Wegener's that's been treated, the ANCA may disappear, but you'll still have the histology. So you kind of have to really put the whole thing together with your clinicians for the Wegener's case. Okay, so that's those for today. So I hope those were helpful and
Really
you
helpful.
picked up some tips.
Actually, Dr. Beasley, there's a question from one of our YouTube audience members. So Tabor,
Oh, we have YouTube audience members.
Yes.
Okay.
we can take the questions. So Tabor asks, I guess for the question with lipid pneumonia, but is it required to do special stains to prove that lipids are present?
No, you're not going to see the lipid if it's been processed through the lab. That's going to be extracted out. So it's really just that classic histology. One thing, sometimes these patients do get super infected with mycobacteria, so you do want to do microorganism stains on that just to rule that out. But otherwise, it's just the histology that you're recognizing.
That's all the questions.
Okay, great.
Thank you.
All right, thanks, guys.
Thank you so much. That's great. I'm kind of seeing.
I know.
Doctor.